Hello, thank you for your interest in blood changes in the coronavirus disease 2019. This COVID-19 pandemic has besieged us all with its relentless worldwide march and besieged us as clinicians with so much new information to absorb. My aim here is to distill the expanding literature into three key principles of understanding to help you better recognize the blood pattern changes in these patients, to signify those changes that have the most relevance to prognosis and pathogenesis, and to indicate the changes to how care could be improved now and into the future through research. A key reference point in how I think about COVID-19 is the evolutionary importance of the blood system and its physiological response to pathogen invasion. What is naturally designed to protect us is the activation of the immune pathways in convergence with inflammatory and coagulation processes. Typically, we would see a surge in neutrophils with bacterial infections and for circulating lymphocyte numbers to fall with viral infections. However, neutrophilia can also occur in response to inflammation, which in itself is indicated by RAC reactive protein or CRP levels and a plethora of elevated cytokines in the circulation. Platelets are, on the other hand, often consumed as part of coagulation activation, and the breakdown of blood clots that are formed is suggested by elevated D-dimer levels. Whilst we are often taught about these pathways as distinct entities, it is actually when and how these converging forces tip over to become maladaptive with potentially lethal consequences that exercises us both intellectually and clinically with patients who have COVID-19. In the first published reports from China, it was highlighted that patients who did worst had high lactate dehydrogenase, LDH levels, which indicates significant cell damage and cell death. And perhaps some of it comes from lymphocyte death. In a separate paper presenting multifactorial analysis, age, organ failure scores, and very high D-dimer levels stood out as independent predictors of mortality. Most of the COVID-19 deaths are because of lung failure associated with development of adult respiratory distress syndrome. And once again, these same blood findings signify those most likely to require ventilatory support and intensive care support. So how does this reflect on the pathology of COVID-19? Well, in post-mortem samples, we see that the lungs are the most affected organ, and here there is marked infiltration of nucleated cells from lymphocytes and neutrophils all the way from the lining of air passages or bronchi to the deeper tissues within the lung. Further findings include occluded or blocked small blood vessels. And now capillaries representing the microvasculature. They have the highest surface area to volume ratio of any blood vessels, which means that any inflammatory damage will render these surfaces much more sticky because they're much more prone to occlusive blood clots or fibrin formation that blocks off vital blood supply to the organ. So here again, evidence of fibrin blood clots and damage to the endothelial lining of blood vessels, which will be a trigger for coagulation. So invariably, when this cuts off further blood supply to multiple organs, multiple organ failure will ensue. And in addition to clots in small blood vessels, there are increasing reports of clots happening acutely in big vessels, manifesting as deep vein thrombosis, pulmonary emboli or pulmonary thrombosis in situ, and thrombotic stroke, including in very young patients. As to how this informs better care, well, we are largely firefighting at the moment and supporting the patients as best possible, hoping that the storm will settle. We need research to pull us out of this and await results from trials happening in this country and abroad to understand how best to dial down this dysfunctional host response that is very much greater than the sum of its individual component parts. In the meantime, guidance from learned societies have stressed the importance of prophylactic anticoagulation for hospitalized patients. And as we speak, the REMAP-CAP Global Research Platform trial has opened a new arm to look at treatment doses of anticoagulation. So, what might all these pathogenic features mean? And here is how I see it and what I think is happening. When cells, including lymphocytes, are damaged or die, they release LDH, but also trigger release of cytokines, especially from monocytes that include IL-6, which stimulates CRP response as part of the acute phase reaction, damage-associated molecular pattern molecules, which are molecules that normally sit inside the cell, but when cells are damaged, they leak out and they're extremely toxic outside their natural environment, toxic to neighboring cells, toxic to neighboring tissues. Thrombin is the enzyme that triggers coagulation, and its generation will lead to clot fibrin formation. So downstream of these pathways, you will find that there is complement activation, which is particularly damaging to the kidneys. There is formation of NETs, which stands for neutrophil extracellular traps, and these act as scaffolds for further clot formation, further thrombosis to happen. And so there is the inevitable potential for a vicious cycle of unintended consequences that further increases that risk of death. So in summary, I hope that I've managed to make the complex blood changes in COVID-19 patients more simple to understand, hopefully more digestible to ingrain, and more interrelatable as we approach that patient with COVID-19. Certainly in my view, the study of hematology, because of its relevance to virtually all areas of medicine, can contribute significantly to effective translation into better care for patients with COVID-19. So I thank you for listening. Do take care and stay well.